We are very appreciative that Dr. John Draper, the Executive Director of the SAMHSA-funded National Suicide Prevention Lifeline, has joined us today. Dr. Draper has been the Executive Director of the Lifeline since 2004, overseeing all aspects of this service, including its sub-network, the Disaster Distress Helpline, and the Lifeline's partnership with the VA in administering the Veterans Crisis Line. Dr. Draper is an internationally recognized expert on suicidality and crisis center practices. He's interviewed regularly by outlets such as the New York Times, Time Magazine, and CNN. Dr. Draper, thank you so much for taking the time to talk to TeamHealth.
I'm delighted to be here, Dr. Schumann. Good to see you.
So it doesn't feel like hyperbole to say that we are experiencing the most challenging moment of our lifetimes, with obviously COVID-19, political and racial divisiveness, economic woes, even wildfires and hurricanes this week. The list goes on. So given all of that, one would imagine that suicidality and the number of persons dying by suicide would be on the increase. Is that reflected in your data?
Well, it's a little too early to tell right now, Dr. Juman. Right now, it's about a 2-year wait before the CDC has any final figures on this year's suicide rates. Unfortunately, we're that far behind, but we do have a number of signals, as you mentioned, that this is a time of extraordinary distress. Most recently, there were some findings that reported from the CDC that more than twice the usual number of people thinking seriously about suicide is occurring right now, at least relative to last year around the same time. It's about 11% of our population right now who is seriously thinking about suicide. There's other signals too that are pretty distressing as well. About 1 out of every 3 people are thinking or feeling anxious, and about 1 out of every 4 people are feeling depressed. Now that's about 4 times higher than the same time last year. So I'm not sure we've seen that kind of numbers nationally, certainly not in my lifetime. So to your point, this really is a unique time. So all of this tells us, even though we don't know what the suicide rates are, that we need to do whatever we can to start preparing to prevent now.
Right. So can you tell us what is being done on your end to gear up for the expansion of suicide prevention resources in light of the risk, at least, of ongoing increases in suicidal behavior?
And kind of drawing back the scope a little bit, the CARES Act from Congress, COVID-19 funding, gave about $425 million to SAMHSA for mental health and substance abuse supports, which will go through September of next year. About 50 million of that was specifically for suicide prevention. Most of that going to states and communities, tribal communities as well. And when we say communities, anywhere from community mental health centers to EDs to also social services. But more than 10 million of that also went to the National Suicide Prevention Lifeline and the Disaster Distress Helpline, which we operate. And we're using that to expand our services, not only on phone, but text and chat, as well as provide some more online services to support people in this unique time.
Fantastic. So shifting over to TeamHealth, many of our clinicians are on the front lines in emergency departments, which don't always have psychiatric care at their disposal. What do you see, generally speaking, when you look at how suicide care is provided in EDs? And can you describe an optimal process that emergency department clinicians can implement when they're providing care to suicidal patients?
Well, I'll give you an easy takeaway. The Suicide Prevention Resource Center has just a terrific toolkit for emergency departments, which outlines some very practical, brief interventions, including a decision tool on whether or not to admit someone to the hospital for suicidality, but more importantly, some of the brief treatments that you can provide in the emergency department. I think what often happens in emergency departments, because you have so much coming at you, and it is kind of a next, 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 and you are in it yourself in somewhat of a crisis state all the time, that it's hard to stop for a moment and actually see the person that you're with and actually listen. And what we mean by that is not just assess for their suicidality, but get some sense of context, get a sense of what specifically is driving their suicidality now, and also what's their history. Sometimes ED docs even forget that there are perhaps past hospital records there that you can look at. So make sure you look at that record if they're there to get any past history, to put all of that person in context. Certainly if there are collaterals there like family or surrogates or anybody that you can talk to who's present with that person. Worry less about HIPAA and more about the individual, how that person can get care. In fact, HIPAA is pretty darn silent on these kinds of circumstances. Whenever there is a person who could be at risk, if you don't do extra things to make sure that they're safe, that's when you're actually more liable. So there's quite a number of things that we can do in the emergency department. And it's important to remember this because EDs and inpatient units, which are often the kind of default care for people who are suicidal, are not really great at suicide care. In fact, about the most recent data, if you're discharged from emergency department for suicidality, you're 28 times more likely than a person in the general population to kill yourself. If you're discharged from an inpatient unit, you're 44 times more likely to kill yourself. So it's not that these facilities are making people worse. It's just that they're not actually doing the job of suicide prevention. So when you look in that toolkit, you'll see there's about 5 different things that can be done that are actually not that time consuming, that can really make a difference. Aside from the listening and assessing that I was talking about, there's little things like sitting and educating the person about their diagnosis and actually working with them and their family members or whoever on a safety plan. On how, upon being discharged, safety plans have been shown to significantly reduce suicide attempts by nearly half. So not doing that is really a problem. It's also important then to make rapid referrals, make sure that they're connected to counseling quickly, and also do follow-up care, anywhere from sending them a card to check to see how they're doing, to making phone calls, those kinds of things that say, we haven't forgotten about you, we're thinking about you, are you okay, did you link to treatment? All of that has been shown to reduce suicides. In fact, about 40 times more effective than statins are in preventing heart attacks.
Well, thanks for that, and we'll be sure to post a link to the resource that you mentioned at the end of this interview. I want to shift gears a bit now. I'm co-chair of TeamHealth's Clinician Resiliency Group, so I'm always focused on the well-being of our clinicians. Right now, my concern is quite elevated, as you might imagine. So many of our clinicians are in the trenches, caring for COVID patients, often immersing themselves in the family systems of those patients who are unable to connect with their loved ones in person. And then perhaps also concerned about bringing the virus home to their own families when they go home. We know that the suicide rate among healthcare clinicians is high, but it would now seem that our clinicians would be at even greater risk. What can these clinicians do to enhance their resiliency? And what can TeamHealth do as an organization to help our clinicians during this especially difficult period?
So really, really important questions that we're actually hearing for the first time. A lot more health systems leaders such as yourself are asking in ways that they really haven't before. Because to your point, the suicide rates among health practitioners, emergency department professionals in particular, are considerably higher than the general population for a lot of reasons. But to your point now, there's a lot of stresses that really put them at even greater risk. We've been in contact with quite a number of healthcare professionals who really told us about all the things that you're referring to, that yes, there's a lot of stressors. I mean, really, we hear a lot of the comparisons with first responders. They're the first responders of this disaster, and that's true. But unlike other first responders in past disasters, where you're talking about police or firefighters, they signed up to put themselves at risk. That's not true of healthcare professionals. They didn't sign up to put themselves or their family at risk. They signed up to save lives, to exact their precise perfectionistic skills that the Hippocratic Oath requires. First, do no harm, to do no harm, and to help repair and recover and heal. Yet they come into situations where it's pretty imprecise and pretty imperfect. In fact, a number of circumstances, they don't have even the right equipment. And certainly with no cure or no vaccine, it can be pretty hit and miss depending on when the person comes in and what underlying issues that they have. Mm-hmm. So a lot of them are feeling very, very out of control. So what is it that we can do about this, both short-term and long-term? I think it first starts with leadership. People such as yourself, Richard, and people actually leadership in healthcare systems themselves. They really need to say the Hippocratic Oath starts with us. First, do no harm to ourselves. We need to be our best so we can do our best for others. And so provide as many supports and training on taking care of yourself and others, and create a caring community as much as possible. And also be disclosive about, what it is that you've done to take care of yourself, and encourage people to do the same. Aside from the leaders, it's really important that from a peer perspective, that there be peer support, because a lot of people are going home feeling like, I screwed up. And we know that healthcare is very much a chain of events that involves a lot of different people doing a lot of different things that can make a difference. So also handling it and taking care of each other is a team thing too. So check in with each other, ask each other every day, how are you doing? Now that can get pretty tiresome. People just say same. But I like to say, all right, tell me same, better, or worse. I want to hear if it's better or worse. Tell me about that. If it's same, okay, but I'm going to ask you every day. But it's very important that we create a culture of actually asking and listening and caring about the answers. I think the third thing that's really important, of course, is self-care. What do we do for ourselves? We don't have a lot of control about what's going to happen while we're at work. But when we get off work and go home, after you kind of take care of whatever infectious concerns you might have in terms of protecting your family, do whatever you can to take control over small things in your life. What is it that you can do to maintain your routine in spite of what's happening at work? What can you do to maintain your physical health, whether it's sleeping, diet, exercise? Keeping those routines help you stay grounded as much as possible. It's also really important to maintain your social health. We talk about social distancing, but it's really physical distancing, social connection. Actually, it keeps us breathing. It produces oxytocin, which is going to keep us comfortable and actually feeling safe, which we need to do when we're kind of in a crisis state. There's also things that we can do intellectually to grow during this time. What are we learning? And most importantly, emotional health, right? I mean, we want to make sure that we're finding time for comfort, relaxation, and joy wherever we can. So staying socially connected, emotionally connected, and also physically connected is very important. And I certainly want to remind people that spiritual health is absolutely critical as well.
Thank you so much. Some great ideas in there. Are there any resources that you might recommend to clinicians who are grappling with thoughts of suicide?
Well, of course, we run the National Suicide Prevention Lifeline, so I'm going to mention that. That's there for every person in this country who could be in suicidal crisis or in emotional distress. Really about 75% of the people that call us are just in distress. But there's some other resources that I also want to recommend. Dr. Mona Massoud in the Philadelphia area is a psychiatrist who started this physician support line in the wake of COVID. She was noting that, look, so many people are celebrating these healthcare professionals who as heroes, and a lot of them are not feeling so heroic. So where do they feel safe to actually talk? And so she established this physician support line, which now has about 600 volunteer psychiatrists working around the clock to help people. So I'll send that information for that also. You'll have that on the end card as well. Certainly, We've got telehealth now in a way that we didn't before, telemental health, which is fantastic because it's not easy, especially if you're working really hard day in and day out at a healthcare facility, to go back to another healthcare facility to see somebody. Of course, you can't really do that now these days anyway. So thankfully, there is the telemental health capabilities. So checking in with the therapist can really help. Obviously, if there's an EAP or your insurance plan, you can look up for your therapist there. But please, please, please remember that the people in your lives who care about you, give them a chance to do that now. They want to. Make space to give them that opportunity.
Thanks for that, Dr. Draper. Before I let you go, I want to mention what I think is a historic move that I think will go a long way to improving mental health care in this country, while at the same time reducing the stigma around mental illness and suicidality. And I'm talking here about the FCC decision to designate 988 as a 3-digit phone number similar to 911 that will bring callers directly to the Suicide Prevention Lifeline. So congratulations on this milestone. My guess is that you're pretty excited that it's come to fruition.
Oh my gosh, on so many levels, for all the reasons that she noted. It's supposed to launch in July of 2022. The FCC did something, as you know, Dr. Juman, something very, very historic just last July 22nd. It's the 16th actually, when they assigned when they signed the 988 number, which is historic for a couple of reasons. One, 988 is not like an N11 number. Typically, all of them have been like 211, 311. This is the first time they ever said, well, look, we've used all of those numbers. The only way we can assign a 3-digit number is go outside of this pool of numbers and grab something that looks like there's an unused area code, essentially. Mm-hmm. So they did that, and that was absolutely historic, something they've never done before. They did it for suicide prevention. The other thing they did for suicide prevention is they've never designated a 3-digit number to give to one entity, the National Suicide Prevention Lifeline. It's typically, when you dial 911, that goes straight to a local 911 center as opposed to a centralized authority that can make sure that all of those services answering are providing the similar kind of service. And if one center goes out, you can have a backup service at others. So again, a very historic thing. But more importantly, from a systemic and a cultural standpoint, it's just transformative. Actually, after we get the infrastructure built, we have to first create an infrastructure for this massive new thing. And again, the National Suicide Prevention Lifeline network is basically a network of local crisis centers. So it's going to have to build on that. But two things to note is, from a systemic standpoint, the transformative effect is when you think about what 911 did to law enforcement and facility and receiving facilities like jails and prisons, an explosion of the use of all of the above. What did 911 do for EMS, for emergency departments and hospitals? An explosion. So what will a 911 for the brain, a 988, do for the mental health system? Naturally, instead of just sending cops out, it should be sending out mobile crisis teams and creating crisis stabilization units. It will actually create, we believe, a transformation crisis services care the way it should be. And this actually goes exactly to your other point about stigma. And that is that, and actually, the ultimate expert in my life is my daughter, who has her own history of mental illness. When I asked her, because I have to, she's 20 years old and she knows everything. So I asked her, what do you think about this 988 thing? This was, over a year ago. And she said, well, Dad, I think it'll do more than anything that could possibly be done to erase stigma against mental illness in the United States. And I said, well, why is that, honey? And she said, well, when we have a medical emergency, we have a number to call. But now, if we have a number for psychological emergencies, people will know that they're real. And they'll also know that it's a caring voice that needs to answer, not cops coming to your doorstep. So yeah, that'll probably do a lot for stigma. And I think it will, my friend.
I think so too. We are so excited that Dr. John Draper, again, the executive director of the SAMHSA-funded National Suicide Prevention Lifeline, has been able to spend some time with us today. Dr. Draper, thank you on behalf of TeamHealth and especially all of our clinicians who are going to benefit from our talk.
Thank you for having me. Good seeing you.
You too. Take care.